Okay, good afternoon everyone. Today we're going to talk about non-pharmacological strategies to induce tolerance in solid organ transplantation. This is part of the webinars of TransplantChild European Reference Network Education and Training Strategy and Education Plan for 2019. Well, my name is Antonio Pérez Martínez. I'm the head of the Department of Pediatric Hemato-Oncoloy Stem Cell Transplantation in La Paz, in Madrid. I'm a member of the Executive Operative Committee of TransplantChild European Reference Network. Well, we are going to talk about this strategy in these points, the current status of the problem of the immunosuppression and stem cell transplantation and solid organ transplantation, the goal of immunosuppression in transplantation, what is the operational tolerance and how to address it by spontaneous operational tolerance patient, regulatory cell transfer, induction of ischemia, and conclusions and call to action. Well, we're going to start with this strategy talking about the current status of the problem and historical perspective. Well, the number of pediatric transplantation performed in Europe are increasing. For example, during the period of 2008 to 2012, more than 5,000 solid organ transplantations were performed in children in Europe, representing an average of around more than 1,000 transplantations per year. In a similar period, a total of 56,000 hematopoietic cell transplantation were performed in kids in Europe. It means that in 1 year, more than 4,000 transplantations are performed in Europe. So between solid organ and hematopoietic cell transplantation, more than 5,000 children receive some kind of transplant in Europe per year. So for this important volume of transplantation, we need immunosuppression. Immunosuppression is the key, and it's a strategy after transplant essential for graft and patient survival, and it represents the most important element in post-transplantation clinical management. However, the chronic use of this immunosuppression is associated with the development of many side effects. We already know that there are an increased rate of malignancies, infections, cardiovascular diseases, metabolic and endocrine disorders, and also there is a direct toxicity of these immunosuppression drugs. In fact, all of these points impact straight on the long-term morbidity and mortality of transplant recipients. But on the other hand, an insufficient immunosuppression could result in rejections. So, being chronic rejection, one of the main reasons for late allograft loss. So we need a more effective and less toxic immunosuppressive medications, or why not oral strategies. Well, from the last century, in the middle of last century, when it was started the different pediatric kidney or solid organ transplant and also hematopoietic stem cell transplant, all of them have developed similar development. For example, at the beginning we started with observe that the surgical problems can be solved, but we cannot solve the medical problems. So until the last century, when we discover or we introduce new drugs after transplant, cyclosporine or tacrolimus, is when survival rate after transplant were increased. And now we are in the phase of trying to explore new donors, a living donor or cadaveric donor from asystolia. So there is this new era of trying to find new donor. However, in all of this case, we need immunosuppression drugs. Well, it's quite similar to hematopoietic stem cell transplantation. Well, at the beginning we had some technical problems, and it was a strategy that in the 1970s was described as useless because most of the people died. However, 20 years later, Donald Thomas received the Nobel Prize because this approach saved many lives. So at this time we have an acute improvement of strategies to induce tolerance. We have drugs, but also we have T-cell depleting strategies. Then, for example, in a mismatch setting, in a mismatch-related setting, we can infuse positive hematopoietic stem cells alone, or we can increase a graft without T cells, or we can remove alloreactive T cells as alpha beta T cell, or naive T cells. So there is a gap we have to try to address between the surgical process of the solid organ transplant, but between the medical care we need to improve survival of the graft and the patient. So how to fill this gap? Well, in order to fill this gap during the development of transplantation, the magic word has been immunosuppression. We need to immunosuppress the patient to tolerance and allograft. So all of the different approaches were to try to find, to figure out which strategy, which drug would be more effective. It could be effective but low toxicity. So we started with steroids from the beginning, then azathioprine, cyclosporine, another CNA, tacrolimus, and now we're introducing new MMF. But not also drugs, but also timing of immunosuppression. So we identified that before transplantation we need to induce some immunosuppression with monoclonal antibodies or monoclonal antibodies. Then we can perform the transplantation, and then we need to maintain this immunosuppression with potent drugs as corticoids and also calcineurin inhibitors. So if there's any chance to make tapering of withdrawal immunosuppression, well, if you do that, it's easy to find a rejection, so you need to increase the immunosuppression with a shortcut of high-dose steroids and rapid tapering to baseline, or if it's not enough with corticoid, you need to introduce polyclonal antibodies or polyclonal cell therapy. So this is the graph where you can find a different approach to induction agent for liver transplantation, heart and kidney, but also how most of them they need 1 year after transplant, most of them they need steroids, and all of them they need for a calcineurin inhibitor after transplantation. So one of the goals of immunosuppression in transplantation it's to induce allograft-specific non-response, maintaining immunocompetence against other potential pathogens and conditions, achieving the desired level of immunosuppression, required balance in preventing rejection, avoiding excessive immunosuppression, and increasing risk of infection, malignancies, and graft-specific toxicities. So, two major approaches to this goal could be performed. First is optimizing pharmacological monitoring during different phases of new drug development, as tocilizumab, abatacept, serotherapy-free conditioning, or which are potent enough to prevent rejection and the respect immune reconstitution after, for example, stem cell transplantation. However, nevertheless, induction of a drug-free tolerance will be the preferred option, as this will be avoid chronic interference with the recipient immune competence, thus increasing the risk of malignancies and infection. Although several different therapeutic approaches for tolerance induction have been tested in the preclinical models of cell grafting, only 3 have been utilized successfully in a still small number of patients. These approaches are based on immunosuppression withdrawal in spontaneous operational tolerant patients. Second, it's something it's not passive. It's try to induce mixed chimerins by an active way, and the other way is to an active way is try to adoptive transfer of regulatory cells, monocytes, Tregs, dendritic cells, mesenchymal stem cells. So with applying these strategies could not only reduce side effects and improve the long-term graft outcome, but also the quality of life of transplant recipient and the cost of immunosuppressive therapy altogether. So this is the reason why it's so important to find this operational tolerance, because the operational tolerance is defined as the acceptance of an allograft by a recipient in the absence of maintenance of immunosuppression. We already know that the theory of immune-mediated rejection was developing in the last century in skin allograft models by Peter Madawar, who was a British surgeon, that showed that serial full-thickness skin allografts in cattle were rejected more vigorously while grafts between monozygote twins. So this finding supported the concept that allograft rejection was an immunological phenomenon with the classical immune properties of sensitization, memory, and tolerance. concepts that have remained pillars of transplantation science until the present day. So this idea of operational tolerance is an important goal that we can address if the graft remains functional in absence of immunosuppression. At the same time, the immune system is not altered. So, how can we achieve this operational tolerance? Well, there are, as we mentioned before, upon transplantation, the cells types of the innate and adaptive immune system contribute to the development of tolerance or rejection of the foreign graft. The evidence suggests that the patient's responses depends upon the relative proportion and interaction of inflammatory and anti-inflammatory subpopulation of these cells. This means that for both the innate immune cell compartment as well as the adaptive immune system, pro and inflammatory subsets have been described, that the balance between them will most probably determine the outcome of transplantation. For example, rejection is promoted by donor-reactive Th1 cells, where their activity is regulated by IL-10 and TGF-beta producing Tregs. Similarly, both pathogenic and regulatory functions have been described to B cells, so even in plasma cell but also macrophage. So it is not only sufficient to determine the number, but also the function of one cell subset, because we need to have a printing of these immune cells that they are involved in this tolerance. It is generally accepted that the balance between donor-reactive conventional effector and anti-inflammatory Tregs determines the outcome of the anti-donor immune response. Indeed, increased frequencies and absolute cell numbers of, for example, differentiated effector memory subsets in kidney but also liver transplant is associated with development of cellular or even humoral acute rejection. In contrast, in some situations, high levels of Tregs, defined as CD4, 25, FOXP3 cells, seem to predispose to tolerance induction. Similar observations have been made for other immune cells, such as B cells, lineage, or myeloid cells. However, there is in some cases when we can find spontaneous operational tolerance. For example, in renal transplantation it is rare, it's estimated about 7%, but however in liver this proportion is higher, and it has been reported by the 20%, for example. The adoptive transfer of cells with regulatory of tolerogenic functions as Tregs or macrophages. This is some studies who said the safety and efficacy in part. In some studies a liver transplant, but also in kidney transplant. There is some multi-center studies, for example in the one study. They have reported that these cells can be successful, reported patients in liver transplant could be withdrawn until 18 months post-transplant. They 1 year and a half they can stay without any immunosuppression. However, to date, the only approach that has repeatedly shown efficacy in actively promoting drug-free graft acceptance has been through the induction of chimeras by transferring hematopoietic donor stem cells together with the transplantation of the solid organ transplant. This has been shown to result in tolerance induction in liver and also in kidney transplant recipients. However, with all tested therapeutic strategies, immunosuppression with active tolerance induction by cell therapy leukemia, it has become clear that this does not work for all patients. So there is some patient that can be selected carefully to avoid unnecessary risk and graft loss, for example. But This is something we cannot address this time because we don't know the printing of this cell at this time. On how induction of mischimerism works, right? It works by the utilizing central tolerance but also peripheral tolerance. There is common biomarkers of rejection that have been described for different organ transplants. However, there is not a mutual signature of tolerance. So we cannot say which cells are involved in tolerance, how we report in rejection. Well, as we have addressed, at the beginning, there are some experiments. They shown to us that during the prenatal period it's feasible to achieve tolerance. There is some experiment from Frank Lilly, Ray Owen, Peter Middlewar in animals, for example in cattle twins, with red cell chimerism, but also skin graft chimerism. But what happened after this prenatal period? Is it feasible? Well, at this time there are three major groups that they try to develop transient chimerisms, persistent mixed chimerisms, or full donor chimerisms as strategies in kidney tolerance. For example, in mismatched HSCT, the Massachusetts group said that transient chimerism could be enough. However, the persistent mixed chimerism for Stanford is needed to achieve tolerance. This is the example of matched kidney transplantation. The Northwest University said that we need full donor chimerism to achieve tolerance. So yes, chimerisms can be obtained. However, there are different ways to introduce chimerism. So at this time, we are not now in the way that no drugs have been developed. They stopped in last century, the last century. So we need also to include mixed chimerism as a strategy because we already know how the immunosuppressive drugs have very impairment affecting immune system, toxicity, and they failure to induce tolerance. So we need a new model, and this new model can be the hematopoietic stem cell mixed chimerisms. These are, for example, examples of transient mixed chimerism, stable mixed chimerism from Massachusetts University, matched HLA living donor kidney liver allografts. These are another example with more aggressive conditioning regimen when HLA mismatch setting and haploidtic stem cell transplant setting in patients who require kidney liver allograft but also hematopoietic stem cell transplantation. But what happens when there is not a living donor or not a Madrid setting? Can we achieve a mixed chimerism using reducing the conditioning or cadaveric donor allograft? This is the concept of delayed tolerance that has been explored in non-human primates by avoiding donor-specific memory T cells, choosing the correct timing of donor bone marrow administration to minimize level of immunosuppression. So this is the proposal of Pittsburgh. In Pittsburgh, there is a concept of cadaveric donor line allografts with this strategy, and they have very nice data. So, what's our conclusion of these webinars? Well, increasing awareness of the long-term effects of immunosuppression has prompted a change in the management. New approaches to immunosuppression for induction, treatment of acute rejection, and long-term maintenance therapy have been considered. New induction therapy is suggested to provide enough immunosuppression to control rejection and thereby protect graft function and survival. The ultimate goal of induction therapy will be to use methods to induce donor-specific operational tolerance. Mixed chimerism is a strategy to achieve permanent operational tolerance. The only active tolerance induction approach is induction of chimerism by co-transfer of donor stem cells together with transplantation with solid organ graft. How transient mixed chimerism should be enough to achieve effective tolerance, as some groups have said. And also the concept of delayed tolerance should also be acquired with the same donor if we choose the right conditioning and the right timing. So now time to call to action. There are two major proposals we're going to address with this topic to the European Council at this time. One is the European Cooperation in Science and Technology Action, because action And the second is the initiative from the European Board of Transplantation working party in combined organ and stem cell transplantation in children. This is the Cost for Kids subcommittee. Well, the European Cooperation in Science and Technology Action is called SHINE strategy. It's a European network for improving pediatric solid organ transplant by hematopoietic stem cell transplantation and other cell therapies. In this consortium is formed by 6 European countries, 1 near neighbor country and 2 international countries. These are the institutions that belong to this cost action. And the other action we would like to talk about is how the European Board of Transplant Working Party and Combined Organ and Stem Cell Transplantation until this subcommittee has been created to explore the role of stem cell transplant cellular therapy as a strategy to induce functional tolerance and after pediatric transplantation in order to implement this practice in pediatric transplant care. So these are the group of the different institutions who are involved in this strategy. That's all for my webinar today. Thank you for your attention. I hope you enjoyed the webinar. Thanks a lot.